Good afternoon. I'm Dr. Alfred Johnson with Johnson Medical Associates, and I'm happy to have today with me two guests, Dr. McCullough, who has been on the program before and has written a new book along with John Leake. It's been a great read and has information in it that will help all of you post-pandemic. To help you understand what you may be going through, if you have long haul type symptoms or just in recovery, or what your loved ones actually experienced. So it's my pleasure to have both of you here today.
Thank you.
And then in the program we'll talk some about long haul symptoms at the end, to kind of help give an idea of those that are continuing to have problems either post-COVID or just symptoms that are hanging on and what's going on in your body and the pathophysiology behind it. So what prompted this book, and how did this book get started?
Well, as the audience will recall, you and I and others in Dallas were the doctors who started out with the understanding that we had a duty to treat, that our patients were falling ill with this novel virus that had come into DFW area, and we felt the duty to treat, but we realized that not everyone in the medical community was with us. And John had returned to his native Dallas from Vienna and was studying what was going on, and then he reached out to me.
I'm a true crime author. I was born and raised in Dallas, but I lived abroad for many years. And through my true crime adventures, I had become somewhat interested in forensic medical literature. And so when SARS-CoV-2 arrived in the United States, I happened to be at home visiting my family in Dallas. And I began to suspect there's some real implausibilities happening here with what we're being told. It seemed apparent there was a massive propaganda campaign, that the nature of this thing that had arrived on our shores was probably being misrepresented in many ways in order to maximize the fear of it. Fear has long been a mechanism for politicians to invoke emergency authority, emergency power. And I thought, what is going on here? I quickly recognized I need a top medical guy to help me interpret what's going on here. Not only a top medical authority, but a top medical authority who is also himself questioning the orthodoxy. He had to have both qualifications. And by a very happy coincidence, the man who's the top guy in his field and who is questioning the orthodoxy also lived in Dallas. So I contacted Dr. McCullough almost exactly a year ago, and we worked on the book for a year, and it's just come out.
Wonderful. I kind of had a similar story with Dr. McCullough, because I was looking for ways to treat these patients early on, and I read the study from Detroit, out of Detroit, where they were doing early treatment, and they kept down hospitalizations and kept their employees employed. I started looking, and I Googled early treatment, and Dr. McCullough's name came up, and it had a phone number, and I called it, and he answered.
And that's in the book. I'm a former program director at Henry Ford. There was a period of my time I lived in Michigan. I really enjoyed my time at Henry Ford, one of the oldest, most respected hospitals in the entire country, founded by Henry Ford, the great motor company, entrepreneur juggernaut who had the vision that a health system could be created, in a sense, almost like an automobile industry, where there was a lot of equity in terms of doctors and nurses, and everybody was on the same team. And I love my time at Henry Ford. And as the pandemic started to hit cities, Detroit was hit hard. A lot of my friends are there. We were talking, and there was great concern that, in fact, nurses and doctors would start to die. And one of the great iconic leaders in cardiology, William O'Neill, who's considered the father of interventional cardiology, and he was my mentor when I trained in cardiology. We talked. He said, we must do something. We must do something. It has to be assailable. This virus must be treatable in some way. And so they organized, it was over a 3,000 patient study, consented patients, carefully collected all the data, and they applied early treatment. And the two early therapies that made an impact, and this was early in the spring, were an oral drug used in rheumatoid arthritis and systemic lupus to reduce viral replication, but it also reduces inflammation. And it turns out, as the data laid out, many received steroids. And it was the combination of an antiviral and a steroid where, wow, they had mortality reductions, substantial mortality reductions, and that got everyone's attention. Peter Navarro in the White House, who had involvement in terms of commerce and supply chain, was communicating with Dr. O'Neill. And then Dr. O'Neill said, call Peter McCullough. So Peter Navarro called me. And John has skillfully captured in the mechanism of a story, not a scientific presentation, but a story about what happened.
I thought it was important to tell the story with a classic dramatic structure, a beginning, a middle, and an end. So the opening act, Act 1, this foreign invader arrives on our shore, and Dr. McCullough and his colleagues are scrambling to figure out, how do we counter this? How do we handle it or treat it or oppose it? So that's kind of the opening. And then I think when the reader is taken through from Dr. McCullough's perspective and the perspective of his colleagues, they will now understand these guys were like military officers scrambling to deal with something akin to a military invasion. And they're doing their best, and they have to exercise their judgment and make do with the resources that you have. So the reader will see them kind of in the trenches trying to make decisions to help their patients with a sort of automatic adherence to the Hippocratic Oath. And then we see that as they begin to discover things and advocate things in order to help others, they start encountering this very, very strange resistance. I mean, it would almost be like, I like military history, it would be like a Marine lieutenant in Fallujah in 2004. He's finally making some advances in securing the city of Fallujah from all these maniacs that are coming in. And he gets a call from a general in the Pentagon saying, none of this corresponds to my West Point education. Quit doing what you're doing. And the Marine lieutenant is saying, well, you're not even here. You're not in the field. You don't see what you're not even interested in my situation reports. So I try and capture the story in this way, and readers are really responding to it. They're saying, wow, I didn't really understand this. It was always a bunch of guys just talking about data and arguing with each other. Here, I think they'll actually be able to see what happened.
Oh, exactly. The book is excellent. It's well written. It's easy to understand. It's not written in medical terms, medical jargon that we talk sometimes and people get confused about. But it's very understandable and an easy read and very informative. So
one thing I've noticed too, and this is common amongst any learned profession, doctors take for granted certain concepts that you guys grew up with and went to medical school with that the lay audience doesn't know. So for example, I'll just give you gents an example. I don't think the majority of the public really makes a distinction between the causative agent SARS-CoV-2 and COVID-19 illness. They don't really understand that there's a difference. Not every human being, his body, his physiology reacts the same way when challenged by this virus. And people don't understand that. So the way this is presented to the public is it's this thing that's coming and everyone is in grave danger of it, including young athletes. Young boys and girls who are as fit as a fiddle, They're practically indestructible. They have to stay at home too. So this massive fear campaign, and that should always cause one to suspect something nefarious is at foot. When you're trying to maximize fear, no fine distinctions being made. No attempt to ascertain a risk stratification. Let's protect these people because they're vulnerable. Other people can kind of go about nothing. Just fear. Everybody should be terrified. And so that's an important component. We really go into the propaganda. These are tried and true campaign propaganda techniques, by the way. I mean, they've been around for a long time. So this isn't really new. The extremity of it was remarkable. So we talk about the propaganda. We talk about what the intelligence agencies called a PSYOP, where you're conditioning an entire populace in order to introduce a new government or a new policy that might otherwise be unpalatable in times of normalcy. We go through all of this, and well, now I'm repeating myself. I think it will elucidate a lot.
We really appreciate it. As we go through the book, and as we've gone through these 2 years of pandemic.
2 long years.
Now we come to this point, and Dr. McCullough, where do you think we are at this point, and the assurance that we're getting back to normal and can be normal in our activity? We see countries are opening up. The illness is markedly reduced in severity with less infections or hospitalizations.
Yeah, there are some clear trends, and the government response and the data are mixed. So I want people to understand this. There are some really good parts of the CDC response. One of them is called the Nowcast system. So when you go on the CDC website, the CDC is actually doing very good sampling of isolates of the virus and doing what's called in silico genomic sequencing. And they do know the different variants as the virus mutates. And where we are now is we've had the very first peak that we had was, looking back, was fairly blunted, was called the wild type. The next one in the United States was Alpha. The next one was Delta, which peaked in the fall, around September or so. And then in December, January, you had this very tall peak. That was Omicron. And Omicron jumped. It almost jumped phylogeny. It had so many mutations. When I was called on Fox News the very first time, Laura Ingraham asked me, Dr. McCullough, what is Omicron? I said, it's almost an evolutionary fluke of nature because it's so mutated. It had so many mutations that it allowed permutations of the mutations within the family, and so it created subvariants. So that big peak that we had in December, January in the United States, that's actually called the BA1 subvariant. Then we have had BA2, BA3, BA4. Right now in the United States, it's a blend of BA2, and then BA4 and 5 are coming on. But it's all Omicron. And what we know is a paper from South Africa, one by Khan, a very good one, shows that immunity that was conferred from an Omicron infection not only covers the family of subvariants, but also gives back immunity, closes the immunologic door on Delta. So this was a very important, that's the reason why Delta basically went away, because when people got Omicron, it closed the immunologic door on Delta, but Omicron did break through natural immunity. There's a paper from Qatar in New England Journal of Medicine showing that about the prior cases of wild type alpha, beta, and delta, the immunity there was solid. It was almost impossible to get a second case there. So we could count on that. In fact, workers used to go, take care of other people. They couldn't get it. But the paper from Qatar showed clearly Omicron could break through natural immunity and cause a very mild syndrome that didn't require any treatment. It was almost like an immune re-challenge. And then Omicron, wide open, broke through the coverage previously with Pfizer, Moderna, Johnson & Johnson. And that's what happened. So December 10th, 2021, the CDC MMWR communication said, warning, 79% of all Omicron patients were those fully compliant with the program. So people say, wait a minute, what's happening? The good news is it was mild across the board. We had peaked in terms of prevalent census in the hospital, number of people in the hospital sick with this, and positive and sick with other conditions. The number, we peaked at about 125,000. I checked today, and right now we're at 23,000. So the hospitals have tremendous capacity. I know in my practice, like you, I treat patients. I haven't had anyone near hospitalization now in 6 months.
Yeah, exactly.
Your same experience?
Same experience, and I had it in January, and I had 2 days of symptoms, and it was gone, and I had prior Delta infection.
Right.
And so
Now, the things I have learned in the last year or so is the importance of virucidal nasal washes. I can't emphasize this enough. Dilute povidone iodine or dilute hydrogen peroxide. You can buy 10% povidone iodine, which is betadine, from any over-the-counter retailer, or buy it online for about $5 a bottle online. Take half a teaspoon of that in a shot glass of water, pinch of salt, and you just need a spray bottle or syringe. And you have to spray the liquid up in the nose. You'll feel it in the nose, sniff it back, kind of choke on it a little bit, and spit it out. Do it twice on both sides, and then gargle, a good 30-second gargle. And you got to gargle and make sure it hits the area where it hurts. And that's considered a good nasopharyngeal wash. If you can't tolerate iodine or don't have access to it, the 3% hydrogen peroxide that comes in the brown bottle, 3/4 of a teaspoon, 1.5 ounces of water, again, a shot glass of water, pinch of salt, same procedure. For prevention, if let's say a senior citizen who has lung and heart disease, they're going out to a family gathering, a wedding, what have you, they're worried, you can actually do that a couple times a day for prevention, proven in studies. And then acute treatment, we go every 4 hours on this. And there are 3 large randomized trials, one by Chowdhury and colleagues, showing a dramatic 80 to 90% reduction in PCR positivity by 3 days. So people worried about spreading it to others, the best way to reduce the chances of spreading it is actually kill the virus where it is, in the nose and mouth. And that trial and others show reductions in hospitalization and death. And that everyone can do that at home. So it's such an important element to hygiene and to reduce spread of the illness. Even one of our House of Representatives, Congresswoman, was incensed. There's out on the social media, why is our government not telling us about virucidal nasal washes? 12 supportive clinical studies, and it makes sense.
Yes, definitely. And the big thing is that if you're concerned about transmitting, as you were talking about, is to do it before you go visit someone in the nursing home.
Yes.
And that helps prevent that dissemination. And then if you're out and about, definitely do it when you come back home. Do it before you go to bed.
And traveling.
And traveling too. So before you get, it'll reduce your risk. And you talk about risk, John.
Well, the nasal thing is fascinating to me because it's an example of, it's a logical thing that has just been completely overlooked. I mean, it's like guys are playing soccer and there's a soccer ball on the field in front of them and they're saying, where's the soccer? It's right in front of you. I mean, this nasal, we've known from the beginning that you breathe this in and it replicates here in the sinuses, in the nose. And then once it's replicated there and sort of cooked away in there for a while, then it starts migrating down into the lower respiratory tract. So it just makes sense that you would hammer it when it's up here. And I recently met a guy out in Provo, Utah, who owns a company called Xlear. Xlear is the trade name. And he has gone so deep into the literature of nasal washing. It goes all the way back to the Vedas, the ancient Hindu scripture, thousands of years old. We know that the ancient Indians, they had oral hygiene. They had some of the first toothbrushes, cleaning the teeth, and then they had some of the first nasal washes that we know about in the historic literature. And it just makes sense. You wash your hands after you go to the bathroom. You brush your teeth before you go to bed. If you've been in a crowded environment with a bunch of people breathing on you, you rinse out your nose. So even if we don't have a massive RCT proving this beyond a reasonable doubt, it just stands to reason And that's what we've noticed in this story is anything presented as, hey, this could help. There's no risk involved. The cost is minimum. Why not give it a shot? It stands to reason there are some supportive studies. The Chowdhury study for the nasal rinse out of Bangladesh is very impressive. It's the real deal. But our government agencies say nothing about it.
In fact, to this day, I was in a doctor's office today and I was mentioning to one of the therapists, I said, to this day, people are given a positive test result and they're given no instructions on what to do. We're into our third year. You'd think everybody would have as a standard of care. And that's the reason why we work so hard at the Association of American Physicians and Surgeons to have a home treatment guide. You think every clinic in America would give that guide out and say, here's some basic things you can do. Reducing the spread of the illness, taking care of yourself. Besides the virucidal nasal washes, in the protocol that's now called the McCullough protocol, there's what I call the OTC bundle, the over-the-counter bundle of other things we can do that's supportive and makes sense, including zinc, 50 milligrams of elemental zinc a day, vitamin D, based on a lot of conversation and available data, of which there are a ton of studies. We recommend transiently 20,000 units of vitamin D3 for 5 days, baseline 5,000 international units a day. With this incredible literature, even including randomized trials showing, high enough vitamin D levels in the bloodstream, almost zero mortality. Vitamin C, but high dose, 3,000 milligrams a day. And then quercetin, a polyphenol supplement, 500 milligrams twice a day. But most interesting is because the infection trips off inflammation and various types of histamines and cytokines, to use famotidine, which is an antihistamine, also an anti-acid medicine, but at 4 times the usual dose, 80 milligrams a day. You can buy all this over the counter. There's a paper on my Twitter feed I just put up in the last 48 hours from the University of Virginia analyzing this, and they found that those who actually had famotidine, the doctors actually knew about this, over-the-counter Pepcid, plus aspirin, because remember, aspirin is anti-inflammatory, but also it's a blood thinner, that those patients had over a 50% reduction in the need for oxygen or hospitalization. It's all started at home. Everything we've talked about is available over the counter. You don't even need a doctor to do this. And what's really frustrated us is that medical schools, hospitals, clinics, government agencies, local TV stations, nobody has given Americans a simple at-home approach for this illness.
Well, we thank you for doing that. Now, with Omicron, so updated, because a lot of us went back to Delta and sick with Delta and doing what you're talking about. Works the same with current infection with Omicron?
It's true. The changes with Omicron are that our government agencies have sequentially withdrawn monoclonal antibodies, theoretically because they wouldn't capture the Omicron. It's been frustrating because other products out there have not been withdrawn and they haven't been changed either, including Pfizer, Johnson and Moderna. But having said that, we've been through the Lilly product, the Regeneron product, the GlaxoSmithKline, now back to Lilly. We're currently using bebtelovimab. It's a 2 cc infusion, and it's safe and effective. I've used it in high risk. So if I have somebody in their 80s and they have heart failure and lung disease, and they're presenting with severe symptoms, I just got this yesterday, but I'm already coughing and having trouble breathing. That is the mechanism. Get a monoclonal antibody infusion. And we do this. I just had a physician in my practice who had this happen. I got her the treatment right away in the DFW area here. And it's been my experience, if we do that, we can skip the next level of prescription antivirals. We can simply add corticosteroids. I typically add montelukast, which is singular. It's now generic. Right. And there are data supporting montelukast as discovered by Dr. Chetty in South Africa. One of the things that I've learned in this is innovation is occurring all over the world, and our media is giving us no window to innovation that's occurring elsewhere outside of our country.
And that's a well-tolerated medicine that's been used for asthma and allergies, calming down the inflammatory aspect of it.
See, this is where I think it would help the public to understand that you have the causative agent and you can attack that with antivirals or try and block it, or so you're actually trying to keep the assailant out or from doing its thing once it gets in. But then there are a lot of these things that are just treating the body's pathological overreaction to it. So the aspirin, the vitamin D, you're just helping the body to stay cool and deal with this in a way that prevents this kind of reactiveness that results in hospitalization. So I think everybody thought medicine works as a sort of a silver bullet. It's an either or proposition. Either, it's like penicillin with an antibiotic. You either just wipe it out or there's no sense in considering it at all. Whereas we know from this, no, you're just taking the edge off the symptoms sufficiently to keep the person out of hospital so they can get through it at home. Now contrast that with what we were told. You can do nothing. Gee whiz, you tested positive. Oh my goodness, you've probably seen on the news 24/7 that this is kind of frightening. So stay home, be frightened, and if things get really horrible, then come to the hospital. I mean, what kind of modern medical reality is this? It's just astonishing, and we have to take 3 steps back from this and put some perspective on it in order to have that full realization. What we have been presented with is the greatest, most catastrophic public health failure in the history of mankind. Remember, at least in the past, they could just say they didn't understand.
Exactly. And you folks who've gotten the news out there, worked on it, have affected positively many people's lives.
Right. Well, you and I, in a sense, rejected the orthodoxy. The orthodoxy was, we cannot treat this. Don't try to treat it. In fact, follow the National Institutes of Health guidelines, which say do nothing for patients at home. In fact, when they come in the hospital, unless they need oxygen, don't do anything for them. We said, forget it. We had a duty to treat. This is like throwing a life preserver out to somebody, a life ring, to try to save them when they go overboard, right? We had a duty to treat. We're not going to sit back and wait for large randomized trials. The current White House COVID coordinator was the minority witness who faced me and Dr. Risch and Dr. Freed in the Senate testimony. It's in our book, kind of gripping narrative of what happened. And there's a critical point where he's basically telling us we don't have enough evidence to try to help patients. And the point is, we have a duty to treat, to do everything we possibly can. And you know what? Doctors did pull through in the end. There's a paper published in JAMA, first author is Bradley, showing that 20% of Americans, high-risk patients who got COVID-19, they did get steroids. If you were to ask me which drug class has the biggest impact on COVID-19 symptoms, I would say steroids, hands down. Inhaled budesonide, supported by 3 randomized trials. Oral corticosteroids, the one used in the hospital is dexamethasone. The one we use in the outpatient arena is prednisone, probably more effective. You can also use hydrocortisone. But when patients are struggling, and we're several days into it, and I usually hear this type of scenario, Doc, I'm coughing, I'm having some trouble breathing, but I am really just wiped out. I'm almost thinking about going to the hospital, wiped out. I'm telling you, when we prescribe prednisone in that scenario, it has a major impact on reducing the intensity and ultimately duration of symptoms. And when I've learned with Omicron, because Omicron replicates 70 times faster than Delta, it's an accelerated syndrome. Where Delta used to drag out over a month or 6 weeks, Omicron's much more compacted, that we've actually moved the steroids up in the schedule very quickly using antivirals and steroids together.
Well, typically in medicine for years and years, the sooner you treated a disease process, the better the outcome was. And I see that all the time, whether it's a sinus infection or different types of infections, you treat it early and it works a whole lot better and the patient has a better outcome. Mm. So early treatment, thanks to you, was out there. A lot of doctors use it. A lot of people had excellent outcomes with it, and we're here to talk about it today. Now, I'd like to go on and talk a little bit about your experience with some of those that had the viral infection and post-viral type symptoms that they are continuing to have and experience, and what type of things we can do about that and help the individuals understand. My understanding is that it, as we talked about, creates an inflammatory response, and the inflammatory response damages the tissues, and whatever organ system occurred or were affected, whether it's the GI tract or the brain or the lungs in many cases, suffered that post-inflammatory damage. And how do we treat it? How do we approach that now? What's been your experience?
Mm-hmm. Well, I think John will tell us that, this propaganda campaign that was really waged on America and waged on American physicians, I think intentionally put doctors on the sidelines. Doctors really don't want to engage with this illness.
This is the thing that we see. It's almost like, I don't want to wade into that pit of alligators, whether it be the media or whether it be my hospital administrators or the medical boards. It's like an area of inquiry that a lot of doctors have just sidestepped. It's just, there's nothing that can be done about this. Hopefully you'll be okay. Best of luck. Come to the hospital. This is what we've seen. One thing that we looked at that I think readers will find interesting is comparing similar situations from the past in which the recognized medical authorities of the day, the sort of College of Physicians of London or the University of Vienna professors in the 19th century, just refused to acknowledge that certain talented observational doctors were seeing things. In the case of Vienna, it was Professor Ignaz Semmelweis, who discovered that particles were being transferred from students in anatomy class working on cadavers to women in the maternity clinic. And he said that they should wash their hands with chlorinated lime. It's what undertakers use. And he observes that the incidence of this fever that affects pregnant women shortly after childbirth just precipitously dropped. And he did a pretty good statistical analysis of this. The incidence of this how do you pronounce it?
Puerperal fever.
Puerperal fever in this clinic went from, at one point, I think it was as high as 22%, dropping down close to zero. He presents his data to the eminent professors of the day, and they all say, you're crazy. Same thing with Dr. John Snow in London. They had this terrible cholera outbreak in 1853. He did the most marvelous, it's almost like a doctor who's a detective as well. It's a marvelous story. So he gets all of this data and he zeroes in and triangulates a water well with a pump handle in Soho. And he says this disease that is killing everybody in the city, whatever is causing it, it's waterborne. It's contaminated water. We must close the well. And the knuckleheads that he's up against are just like, no, we're not going to do that. And then this titanic battle, he persuades them to take the handle off the well. The incidence of cholera just crashes overnight, and they still don't believe him. So the problem with human nature is we are very much swayed by the perception of prevailing authority. And we see this battle in history that there'll be an innovative observational doctor who has a real insight. Logically, you think his insight would be embraced, but oftentimes we've seen in history that it's suppressed and rejected.
And fast forward now to this post-viral syndrome injury. Patients were telling doctors, listen, I don't feel well. I've got brain fog. I've got muscle aches. I've got numbness and tingling. It hurts when I take a deep breath. And what's available right now in the medical literature is the following. The greater the duration and severity of illness, the greater probability of these post-viral illness symptoms. And particularly those in the hospital, wow, it's at least 50% of people months afterwards don't feel the same. And there's physical manifestations. There's weight loss. There's loss of muscle mass, hair loss, change in the nails and the skin. And people listening will, who have experienced this will know what I'm talking about. There are no randomized trials of various approaches, nor is there even really a categorization of the array of illnesses. But what we've learned is actually from tissue samples and autopsies, one by Chertow and colleagues from the National Institutes of Health, showing that the virus is alive and replicating up to several hundred days afterwards. And that explains why the PCR is intermittently positive. In the literature now, there's somebody who's, from the very first illness, is PCR positive for several hundred days afterwards. And so we have learned over time, we use the test simply to diagnose somebody when they're acutely sick, and we don't keep doing testing later on. Testing doesn't prove anything later on because somebody can be intermittently positive, not be contagious, but intermittently positive for months afterwards. The second observation is that the virus is everywhere in the body. It's been found in the brain, the lymph nodes, the skin, all the various organs. It makes sense, and the body is trying to get rid of it. The dangerous part of the virus is the spike protein, and the spike protein causes organ system damage, causes blood clots. So my approach to these post-viral syndromes is make sure we make an exact diagnosis of serious things. Example, headaches. We must diagnose a stroke or blood clot or bleeding in the brain. So based on physical exam and presentation, we may get a CT scan or an MRI. We must diagnose peripheral blood clots, people with leg swelling, leg pain. We have to do Doppler studies, ultrasound studies to identify. And so if there's blood clots, we need treatment. What I'm finding out is the blood clots are not easily treatable, Al. They don't go away. And so we're using full dose blood thinners, sometimes full dose aspirin, even some naturopathic other treatments. Some people are using nattokinase and lumbrikinase because we don't have other things right now. The spike protein is there in the body. It looks like for a long time after the illness, and it's driving blood clots. It also drives neurologic injury. We are getting a sense that this has been a tremendous catabolic strain and that nutraceuticals, vitamins, and supplements are playing a big role.
Well, they support the body's metabolic system, and it's the only thing that does that. And so you have to have good nutrients and supplement them in fairly high amounts, as you've been talking about in some cases, to help the liver, the metabolic system to really function. I see patients that have continued symptoms, and I'm going back and looking at history on these patients to find out what they were like beforehand. So many times in medicine, we just get a history of the chief complaint or the original cause of what's going on. Well, I got short of breath at such and such a date. Well, how were you before that? What was your lungs like before that? What were you experiencing before that? And there's many people that I see that have different types of disease entities or abnormalities in their body functions prior to COVID. And with COVID, the inflammatory response that we talk about has just enhanced that. So they have enhanced conditions post-COVID that they didn't experience before, but it was part of what they had before. And one of those things is just mold exposure. And indoor mold can be natural mold that just produces mold spores, such as cladosporium, but then there's the classification of black mold that occurs indoors that produces mold toxins. And these are chemicals that are neurotoxic by definition and are screened for in our food source, in our grains, in what cows eat, and in what we eat. And but our houses aren't screened. If you get damp indoor environments, then those molds can grow in that environment. If it grows behind the wall, you may not see it, but that chemical is excreted. You breathe it in, your body retains it. And I see people come in post-COVID and they say, I can't explain my symptoms. I'm still foggy-headed. I'm still fatigued. I have joint pains and aches. I have muscle aches. Now we're able to measure in the urine the mold toxin levels. And we see those toxins are quite high in many of these individuals. And with that, then you have to work on getting the toxins out, just like, we're talking about getting the viral load down.
See, this is a real spirit of inquiry, and I'm approaching this as someone who's been interested in medical history, but I think it is going to be guys like you who show the way forward and enable us to learn, to help our patients. This constant spirit of inquiry, like you looking into the presence of mold in the household. Dr. McCullough, he reads literature every single day on, what are we learning? Every day. It doesn't end. Knowledge doesn't reach some sort of authoritative pinnacle, and that's it. So I think the mold part of this is fascinating, and it raises a question that I've wondered about. We've talked a lot about mass formation psychosis. I've wondered if there might be some result, some sequelae from COVID-19 syndrome that is making people agitated, anxious. I once read a book. There was a theory about the great witch trials in the 17th century, late 15th, early 16th, and then in the New World, and the Great Salem witch trial of, I believe, 1630. And this guy had this funny theory that the grain supply it was an unusually Europe and North America were unusually damp, very high consistent rainfall, and that there was a kind of mold that might have gotten into the grain supply that makes people nuts.
Exactly. Well, and there's two good studies in the United States on contaminated corn, with the mother eating this contaminated corn containing mycotoxins and having anencephalic babies. There's one in Texas and one in Washington State.
Well, I would say
exactly.
I would say this much, that it's clear that the viral pandemic and the infection itself is interacting with the human immune system in a major way. And it's not just during the acute illness, it's afterwards, whether it's distracting the immune system, whether it's promoting reactivation of latent viruses that are in our chromosomes, including the varicella zoster virus, the Epstein-Barr virus. There are others. There's no doubt that the immune system is being played with, if you will, if not distracted. And now that we have some evidence from a paper from the National Institutes of Health by Froman and colleagues, which is, I think in many ways disturbing, those who have actually taken the mandated forms of inoculation, they actually have an impaired immune response when they do encounter the virus. They have a lesser degree of antibody response against the virus. There's a paper by Hakim and colleagues in the natural state where we get the virus, and there's at least a library of 15 different antibodies that are generated. There's probably way more against the spike protein, the nucleocapsid, the envelope protein, polymerases, etc. Now, when we receive one of the messenger RNA products or adenoviral DNA products to try to prevent COVID, the library of antibodies is just against the spike protein. But you'd hope that when there's a breakthrough infection, the body would give its full-throated immune response to the whole virus, but in fact, that's not what we're seeing. So right now, the majority of patients in hospital in Canada, the UK, the EU, South Africa, Israel, are people who fully took 1, 2, 3, or 4 administrations of these. They were expecting to get some protection, and they've been burned with no protection. They're in the hospital, they're sick.
We have a lot to learn, that's for sure. But yes, I see, the patients with persistent symptoms, their immune system is affected. I do a lot of allergy testing in my office to look at cause and effects of environmental factors, foods, and I see that many of these people before COVID said I didn't have any sensitivities. Now they have sensitivities. Now they're more sensitive. They're hyper reactive.
Well, there's one thing that's clear. is that the olfactory nerve, as well as the otic and vestibular nerves, are affected. The number of people who've lost their sense of taste and smell, particularly smell, prolonged, and the number of people with ringing in their ears and a sense of imbalance is through the roof. And I think it actually may be even more with Omicron, because Omicron is resident in the sinuses, and it is just replicating. The olfactory nerve, the nerve that actually gives the sense of smell, is at the roof. It's actually the roof of the sinuses. And I feel even more strongly that we should be really pushing these nasal washes and sprays. We talked about, homemade hydrogen peroxide, homemade povidone iodine, but there's products you can buy. There's Cofix RX, which is a little stronger povidone iodine, as well as Clear. John talked about this, XLEAR. Do you know, in Finland, they've actually had a regulatory body approval of a nasal spray that's antibodies against the virus. So there's all kinds of innovations out there. There's been a colloidal silver. When I first started working with these oral and nasal virucidal washes, our ENT doctors, including some doctors here in Dallas, say, yeah, we've been doing this forever for chronic sinus infections. I had on the McCullough report, my podcast, a doctor who did a terrific job, an anti-infective dentist, who said, yes, believe it or not, they even use dilute bleach, sodium hypochlorite, just a few drops of bleach, and you can't use it up in the nose, but use it effectively to kill Epstein-Barr virus, cytomegalovirus, or other viruses. And when former President Trump actually mentioned bleach, he was actually, someone probably was talking to him, probably an anti-infective dentist, said, listen, we can do something there. And it came out badly, but believe it or not, the innovation has been unbelievable. There's another approach. I reviewed it with Dr. Hepburn, who's a very well-respected doctor in the Bahamas, and is coming up on my show recently where I had a pharmacist and a doctor on describing this. One can actually use a methylene blue wash, believe it or not, in the mouth, and then just put in a probe that emits infrared light and actually kill microbes in the mouth and the sinus. They've been using it for other approaches.
Speaking of our former president, we talk about this interesting paradox that happened in public affairs in the United States, where President Trump, he was actually right about a lot of stuff, but factually speaking, he was on the right track. But he had such a peculiar way of communicating that, you sort of had to translate, okay, what he's saying is actually true. It's just he has such a peculiar way of communicating.
Just don't drink the bleach. Couple drops, and and these virucidal washes. But I can't emphasize it enough. If everyone listening to this would have some povidone iodine or hydrogen peroxide. A few months ago, I was asked by some family members of Martin Luther King to go to Atlanta and talk about this and say, Dr. McCullough, do you know the mortality rate among African Americans is double that of Caucasians? And I said, is the African American community getting any practical advice? Are they getting any early treatment? They said, no, we're not getting anything. We're scared to death. We have rates of obesity and diabetes in our population, and we see these deaths occurring. And I explained to him just the virucidal washes. They said, Dr. McCullough, we all have a brown bottle of hydrogen peroxide. Are you telling me that this could work? That I said, yes, it does work. There are very good studies supporting it. Very dilute. Right. Very dilute. If it burns in the nose or mouth, it's too strong. Exactly. And never drink or swallow these. Just use them locally.
Well, even Listerine was used.
Listerine and Scope, they work.
Yeah, exactly.
Listerine and Scope work, yeah.
So, well, excellent. These are excellent thoughts and facts that we have based our thought process on in trying to help people that we see or our individual patients. I know you get all kinds of calls, people wanting help, and today, hopefully what we've talked about is beneficial to help those people with persistent symptoms. One of the things we haven't talked about yet is how we actually work on healing the post-inflammatory response or the part that has been injured. I see patients that have come into different universities to their post-infective kind of clinics they're running, and I say, well, what's going on? They said, well, all they are doing is asking us a bunch of questions about what we are experiencing, but really don't have any solutions for us on how to feel better and to improve ourselves with it. Do you have any suggestions on?
I wish I did. I sense this great unmet need there in the population where people generally don't feel well. I'm an allopathic doctor. I prescribe prescription medicines. Outside of these defined syndromes of blood clots or like heart damage, myocarditis, outside of a defined syndrome, I am getting a sense that there's not much of a role for prescription medications. There may be a much more of a role for homeopathic, naturopathic, lifestyle approaches. I just had on my program Paul Merrick, who's a critical care doctor now, is completely devoted to the viral pandemic and solutions. And Paul was reviewing the data on exercise, on intermittent fasting, on other things to try to get the body. The problem is the virus is in the body. The spike protein is in the body. Whether you've had the virus or taken one of the inoculations, the spike protein is in the body, and the body needs to clear it out. The body needs as much immune system juice as it possibly can get. The healthiest lifestyle. Now would not be the time to go into heavy alcohol, for instance. Now would not be the time to get into a lifestyle of sleep deprivation. I think sleep is very important. And now would be the time to dedicate the effort towards physical conditioning. Many people have lost weight, and they can start from a new lower baseline to build fitness.
Exactly, and that's been my experience in seeing patients that are having ongoing symptoms, is to encourage them to exercise, and you have to start out slow, need to work with flexibility as part of that, because these people have been lying around stiff. So doing exercises, and maybe we should do a kind of a program sometime on what exactly to do with it. But exercise is important. Diet is important. People have certain foods that they react to. We know the virus affected the intestinal tract because there's intestinal variety of it. When your intestinal tract is inflamed, you absorb whole food products, which then causes an immune response to that food, and you become sensitized to that food.
There's a recent paper in a gastroenterology journal where they did biopsies of the small bowel. They found the virus there 4 months later.
Exactly.
Well, this raises a question. I mean, is this virus in some ways analogous to some of these other viruses that sort of in effect hide? They become clandestine. I think of HPV, herpes simplex, I guess herpes zoster, that they somehow evade detection from the immune system and then can be reactivated. I mean, do you think we're looking at a similar thing here?
It's possible. We really don't know at this point.
Some studies have shown partial reverse transcription, meaning that the virus doesn't do a complete install into human chromosomes like chickenpox does to become shingles, or Epstein-Barr virus does, like mono becoming later on EBV. But there's partial. The interesting thing is it's been shown in a paper by Banzel and colleagues, as well as by Patterson, that parts of the virus get enveloped in a phospholipid sphere called an exosome. Right. And also, the virus is stuck inside white blood cells, inside CD16 positive monocytes. Bruce Patterson has shown this. So the virus is in us. It's not free floating around, but the body is trying to contain it. And I asked Bruce Patterson, I said, Bruce, is there any other illness like this? He said, yes, there is. Lyme disease. Lyme disease, in a sense, there are fragments of Borrelia burgdorferi, the organism that the body has a hard time clearing out. Now, you get a strep infection, you get a staph infection, you get a typical cold, your body knocks it out, clears it out, gone. But some of these other infections do linger. And you're right, some of them evade the immune system. I'm not sure this is classic reactivation, but I think it's immune evasion. The other thing we know is it goes everywhere in the body. And it has been disturbing, but it's been found in the brain. It's been found in every organ and tissue in the body.
Yes, and that presents a big problem because most of us are doctors out there are specialized now, so they deal with one part of the body.
Right. Yeah, good point.
And luckily, you're here because your background's internal medicine. You practice general internal medicine plus cardiology.
Right.
Plus, you have your all your background in research and can understand that and put this all together for us. And then there's other doctors that, like you mentioned, that are innovative in their approach with it. And one of the things that I've found is part of the treatment, in which I used on myself when I had COVID with my lung involvement, was hyperbaric treatment, where you breathe 100% oxygen under pressure. It speeds up your metabolism. It helps healing. It's the only thing we have in medicine that really enhances the healing process, and we use it all the time in wound therapy to heal wounds, both in diabetics and in other non-healing wounds. And it helps with the brain fog. It helps with the fibromyalgia. It helps with the energy because it speeds up the mitochondria function, and so that's what produces ATP, which is our energy production process. And we see more rapid recovery with that.
Well, John, we should celebrate, in a sense, the pandemic as a springboard for innovation, right? So we were hit with this pandemic, and what Dr. Johnson is telling us is, instead of a cycle of fear and despair and more fear and despondence, that this is a breakout time. This is a time of which we ought to have a panoply of new approaches. We ought to be having conferences. We ought to be talking as much as possible. Instead of being in isolation, we should be encouraging conversation. Americans want to go back to normal. I think doctors in the medical system want to go back to normal. Are there examples in history where we've been hit, the world's been hit by something, and then we rebound with innovation?
That's a great question. I think that we oftentimes learn a lot through war. The experience of warfare, of the trauma. I've heard that a lot of trauma surgery was actually discovered and developed by guys in the field. It was figure it out. You've got severe trauma, do something, figure it out, and these guys would do something, figure it out, and then they would record it. So it is almost like the earth has been struck by a world war, and a lot of guys just kind of decided, I can't deal with this. I'll have to kind of stay in my lane of what I'm accustomed to in my practice. And then you have guys like Dr. McCullough and Paul Merrick and others who have said, no, this is an opportunity to learn. Maybe you guys ought to start your own medical journal.
That's a great, well, the 21st Century Cures Act, which is an interesting document that we should be following, says that we should consider all available sources of evidence because of the freewheeling nature of this conversation, going from activation or exposure or representation of mold antigens to methylene blue to hydrogen peroxide to povidone iodine, the range of things that we've talked about. We have to have enough signal of benefit or enough hope before we invest in a randomized trial. Randomized trials cost millions and millions of dollars. We better really have a lot of observational evidence developed before we can launch a randomized trial. So we have years of observation ahead of us before we get to that expensive stage of trying to pick a therapy and do a randomized trial.
This goes to the heart of a chapter in our book about this marvelous professor in Marseille, France, named Professor Didier Raoul. He's a big character in our story, and he was himself a treating physician, and he was the director of a research hospital in Marseille, France. And he is this towering figure of microbiology. His ancestors are actually doctors. He had a great-granddaddy who himself was a microbiologist, and he came at this from, I've been studying viral illnesses for 40 years. There are things we can do straight out of the gate, if we have an imagination, if we have an open mind, to treat this. And he immediately found himself on the other side of this chasm of there's only one way of dealing, of tackling medical issues, and that is randomized controlled trials of new medications that have to be invented in labs. And he's saying, no, that's great if you have time to study and develop and test new drugs. I don't have time. I have patients arriving at my clinic right now. Yeah. So exactly. I can't tell my patient, stay cool, a randomized controlled trial of this new thing, it should be available, 18 months from now. No, I have to treat them now. And so this becomes a kind of archetypal conflict that we see in our book again and again. And then, at a certain point, DDA, Raul, he's so funny. He tells the press, I can't even talk with these people. They're so stupid that it's not even worth my time. I think that observational data, sharing of observational data, maybe in the medical profession, it's like a bunch of guys trying to solve a big crime. I mean, you see now, I think there was a Netflix story about there is this successive crime, some crazy psychopath is killing cats, like assassinating, executing cats on camera. So all of these pet feline-loving sleuths all over the world start sharing their investigative information, whether it be electronic signals or studying the accent of the villain or certain characteristics of the setting. And all of these guys sharing information together figure out who the guy is. So maybe doctors should start thinking of themselves as sort of an investigative team.
Exactly. And I really appreciate both of you today to come and share your experiences, your knowledge. History is so important because we learn from history. And there's no need to learn things over again if we can learn it from history. And so many times we forget that. We forget what's gone on before. Our experiences are most important. Dr. McCullough included his mind and his willing to get out there and to talk about what is in the literature, what are the facts, what do the studies find, and put it together in a format that both the public and other doctors can understand has been most helpful. And I really appreciate your help because you've helped me a lot.
Thank you.
I appreciate that we can get together today and take your time, both of you, to come and talk about where we are now in our post-pandemic era.
Very good. Thank you.
Thank you.
You're welcome. Thank you.